meeting.
We'll start. Good evening, everyone. A warm welcome from India Vision Institute. This is Dr. Kalpa, Senior Manager for Education at IVIR. And thank you all for joining us today for the third talk of Excellence in Vision Science, a monthly lecture series that presents the research work by experts in optometry and vision science. Today's topic is research in eye health, need and scope. Very happy to introduce our speaker, Dr. Anuradha Narayanan. She is the principal of Elite School of Optometry, Shankar Nethralaya, Chennai, program in School Eye Health and Community Optometry projects run by Shankar Nethralaya. Graduated from Elite School of Optometry, she has also received a doctorate on improving the school children's eye health from Shastra University. She is also a fellow of American Academy of Optometry and has received a postgraduate diploma in health economics from the Public Health Foundation of India and FBDO from UK. Prior to taking up teaching and community activities at Shankar Nethralaya, Dr. Narayanan was the optometrist in charge of LASIK clinic at Shankar Nethralaya. She was instrumental in Shankar Nethralaya receiving the SN Shah Vision 2020 award for her services towards women and child eye health. She's also a recipient for several research awards like the Best Research in Optometry, Dr. Narasimhan Memorial Award, the Ruby Manik Award for the year 2016 to 2017, and the Women of the Year 2019, Outstanding Optometrist of the Year, Best Junior Faculty for 2009-10, and Best Senior Faculty 2015 and 16 from Medical Research Foundation. Apart from this, she's also a recipient of various community service awards and eye donation pledges. She is Nehru Fulbright Indo-US Science and Technology Forum awardee for the year 2014, and she has received several grants for community outreach activities. She has some various publications to her credit and is also a reviewer for journals. Thank you so much, Dr. Anuradha, for joining us today. Before we start, any questions can be posted in the Q&A section or chat box here. This session is live in Facebook. So audience who are in Facebook, you can also post your questions in the comment section. Happy to take that to Dr. Anuradha. Very happy again to have you here today, ma'am. And over to you.
Thank you so much, Kalpa. While you were telling about my background, I was just traveling to my good old days when how I joined Shankar Nethralaya and just looking back at my journey. Thank you so much for your kind introduction. Shall I start sharing my screen?
Yes.
Good evening, friends. Thank you, India Vision Institute, for giving an opportunity to talk in the monthly lecture series as part of Excellence in Vision Science. I'm glad that I could share my research experience in the field of community eye health. People who know me for like more than 20 years, they know me as a clinician. As Kalpa had mentioned, I was the optometrist in charge at Shankar Nethralaya in the LASIK clinic, the refractive surgery clinic. And later people know me as an academic professional, as a faculty of ESO, and now as the principal of Elite School of Optometry. For almost 20 years, I have been a faculty here. And my research journey started as late as 2013 when I started my PhD program, and I enrolled into the PhD program. And my publication journey is quite nascent in 2015. But this has given me enough opportunities, and I had the right questions for which I wanted to find an answer, and that's why I am part of this team now. That's the secret that I wanted to share with you. Though I started very late, asking the right question is the crucial point for being a good researcher. So that's the secret recipe that I wanted to share with all of you before I begin my session. So what is research? Actually, it's like a scientific inquiry. This is what the dictionary says. But it's a scientific inquiry. It is aimed at discovery of facts or to collect more information about a subject. It is finding an answer to a question in your area of interest. Now, that's very nice way of looking at what research is. It's basically to find an answer to a question of your interest. So let us go further, and I wanted to share with you what my questions were when I started my research journey. The most easy questions that always there are some pressing questions in the world, is it not? What came first, chicken or egg? Who gets first, police or thief? No, these are the common pressing questions that I am frequently reminded about and frequently encountered also. Most of you would also be encountering these questions. So these questions basically intrigue us, is it not? These are the questions that kindle our curiosity. There are questions that would want us to find answers to make our lives better. Like, for example, which share is best to invest on, or which investment is likely to get us big returns in a short duration of time. Like, these are questions that we want to ask ourselves to make our lives financially better, is it not? So questions are forever important, be it research-based questions or a scientific inquiry or any other questions for the lives of people. Questions are very, very crucial for further progress in life. Have you, encountered any such pertinent questions in the field of eye health and vision science? That is what I want you to think about today. Do you have any pertinent questions in the area of community health, the answers for which will benefit millions of people with vision impairment, the answers of which will cater to millions of vulnerable population with eye care needs? So, well, our community team, eye health team, had our share of questions, which made us seek answers for many of these questions that we had. Our research was systematic, our search was diligent, followed protocols and evidence-based guidelines. So that was the reason why our answers were strong, and it was constructed on solid evidence, so that our answers to many of the questions in the community eye health became a model, and many have started following this model. So what are these questions? I'm going to share these questions, like what our research team had, our community eye health team had. But before that, what was the need that took us to those questions, and how we decided our methods to arrive at answers, and what changed after we found the answers? This is what I'm going to share today. But before I do that, I would also like to share some landmark research that changed or still changes the way community eye health is looked at. How do you think uncorrected refractive errors get so much of attention that it needed actually nowadays? Have you ever, all of us now agree that uncorrected refractive error is the most common reason for vision impairment in every country. This is what is being discussed, and there are a lot of publications, research works that are done to understand the uncorrected refractive errors. So previously, what was happening? Okay, previously, in the sense, this was around 2004 to 2006, if I'm not wrong about the timing. Previous reports in the vision impairment were based on the definition of best corrected visual acuity, and the vision impairment was not defined based on the presenting visual acuity. So what difference does that make? We can see that this was one of the articles that was published in 2006, where that time the estimate of visual impairment by the World Health Organization, it shows that there are 161 million persons worldwide having vision impairment, including 37 million blind. Okay. But on the basis of, you can see within the brackets, best corrected visual acuity of less than 3/60 in the better eye. So this was what was projected as the prevalence of visual impairment worldwide during that time. Okay. there was an assumption that uncorrected refractive error was taken care of when you take the definition of best corrected visual acuity. So people were tested, their presenting visual acuity was assessed, their best corrected visual acuity was assessed, but the results of the best corrected visual acuity was what was projected as the prevalence of visual impairment. But this research team actually questioned that idea. Their team had a different question. Are all these people who are actually considered as not visually impaired, because no, you consider only best corrected visual acuity, have they received their spectacles? Did they receive a change in their status of visual impairment from their presenting visual acuity to the best corrected visual acuity? This was the question that this research team asked. And in their results, they said, considering that not all those people who were identified with vision impairment in their presenting visual acuity, the number of people who are visually impaired is actually 259 million, 61% higher than that commonly quoted WHO estimate. So this research team, based on their inquiry, they wanted to redefine or represent the way visual impairment prevalence was looked at. So this was a major breakthrough, and then onwards, uncorrected refractive error started getting the prominence that it actually required. So it was not an assumption that spectacles were given and then the uncorrected visual acuity was taken care of, but a true representation. Studies started reporting both presenting visual acuity and best corrected visual acuity, and the gap between these two was considered as the prevalence of existing uncorrected refractive errors. This was a big change, big research work that brought a change in the understanding of community eye health, the needs of the community. I thought this is a very, very apt start to today's session, how research in the community eye health changed the way we look at things. And that's why I thought I should start with this. And we also have a lot of questions, right? About, do you, like always, we are curious in our mind, what is the status of blindness and vision impairment in the country? Okay, so we always want to know the current prevalence of our own country or other countries. We want to know the status of blindness and visual impairment for all the age groups, across the states, across the genders. So we want to understand the status for every country. So I just wanted to share with you this survey from, this is the National Blindness and Visual Impairment Survey of India. This is released by the Ministry of Health and Family Welfare. This is the 2015 to 19 report. It's a robust methodology covering all these districts and representing the entire country. So this is a national survey and then giving results about visual impairment and blindness in India. So every now and then these results get updated, and these results are accumulated and gives us a lot of information as to which are the areas we should look at for working in the community eye health field. And I'm just sharing with you the prevalence that was given by this study for ages more than 50 years of age. You can see the blindness and the various categories of vision impairment, and you can see the prevalence gender-wise and also the total prevalence. So such information gives us an idea as to what are the areas, which age group needs more attention. So these research paved the way for better understanding of the community eye health status of a country or of different countries too. There is another interesting note that I thought that came to our attention. This is like our research team always we wanted to present the prevalence of information about the prevalence of vision impairment, refractive errors from among the school children. So when we were looking at a lot of research articles, we were seeing that the prevalence was reported for myopia and hyperopia. And you can also see that most of the studies that report on prevalence use what is called as spherical equivalent. I'm sure all of you know what spherical equivalent is. And the spherical equivalent method uses a definition saying that if there is the spherical equivalent is higher than -0.5 diopters, it's considered to be myopia. If the spherical equivalent is higher than +0.5 diopters, it is considered as hyperopia. Most of the studies on prevalence was reporting these values. Of course, there are other methods of representing refractive error related information using vector analysis and all, but this is what was frequently reported. So our research team, when we wanted to present our results, we wanted to share our information as a publication, we had a question in our mind. Okay, there is, okay, the definitions of myopia is available, the definitions of hyperopia is available. Anything higher than minus 0.5, anything higher than plus 0.5, we know that. What happens to those between minus 0.5 and plus 0.5? So people would generally have that feeling these are very minimal, these could be emmetropic people also, but are all of these people emmetropes? I just want to give you one example. We just wanted to see, like, for example, take +1 diopter sphere with a -2 cylinder axis 90. The spherical equivalent of this is add half of the cylinder to the sphere, it becomes 0. But is it not a refractive error? This is a case of mixed astigmatism, and it is very much a refractive error, which could cause difference in the vision. It could cause symptomatic symptoms to the patient. So this is a refractive error, but in most of the studies that are presenting on the prevalence based on spherical equivalent, such refractive errors would not be represented. This is what our research team felt when we do this based on spherical equivalent. So where does these refractive errors get represented? So when we wanted to publish our report on the status of eye health among the school children, so what did we do? We, apart from quoting the prevalence of myopia and hyperopia, we cannot name it anything else. So we introduced a terminology called as other refractive errors based on spherical equivalent methods. And if you see, this is a big data from the government school children, almost 91,000 children, where the status of their eye health were analyzed from the study. This is the Shankar Netralaya School Eye Examination Study. And we started reporting in all our publications this other refractive errors too, because the method of using spherical equivalent does not cover all the refractive errors in total. You can see it is a 0.82% of these other refractive errors that were present among the school children that was otherwise not getting represented. 0.82 of 91,000 odd children is too big a number to go unnoticed. So this is another important information that we thought, good research when we want to profile the prevalence, we wanted to ensure that these gets mentioned everywhere in the research studies. Okay, so we started reporting these in between values as other refractive errors in the school eye screening method, and because there is no other provision when we are using the spherical equivalent method. So keeping these numbers in mind, and our representation are from huge numbers, so this cannot go unnoticed. That was what our research team decided. So these questions, these are only few examples of why robust research is needed in community eye health. All these discussions show us how research in community eye health makes us understand the needs properly, deliver the services according to the identified needs. But the needs and scope does not stop there. I would share few more of our questions based on our community needs too. So if you see here, this is the first question that came to us actually. There are so many with vision impairment in India, especially children, but they remain untested. Is it possible to screen as many children as possible within a short duration, not compromising on the quality? Actually, this came from the community. This question came from the community when we were busily doing school screenings as part of our institutional protocols. There were a lot of requests from many people who partnered with us to whether we can cater to more children without compromising on the quality in a lesser time. But we didn't want to just like that start doing the screening for more children and all. So this was often posted by many of our partners. There are so many children, so why can't we increase the number? So this was the question that was given to us. So what we started doing this, actually this was a big challenge, okay, like with millions of children remaining untested, whether we'll be able to come up with a methodology like that. So our team started exploring all aspects of the screening, including the capacity requirements, the training needs, the infrastructure that is needed for doing something like that, the logistics, the operational logistics that are required. And we started documenting each and every aspect of these and every step to see the feasibility of whether such a model is possible. So finally, what we did, our team could complete this process and we conceived a unique model which was called as a single day mass vision screening, and how optometry schools can adopt this model and then cater to more number of children. We we covered, this is an article that we published where we covered almost 12,448 children using this protocol in a single day. This was a 3-phased protocol, including the follow-up. It became a 4-phased protocol, but the 3-phased protocol, it outlined every step of the process. Pre-screening, what are all the operational logistics, capacity building, training needs, requirements of infrastructure, and during the screening, what are all the clinical protocols that will be in place. Post-screening, what are all the various things that are needed. So each and every model or each and every step of this model was documented in the study. And we could also repeat this on many occasions. So usually when we were able to, whenever we upgraded our protocols, our clinical protocols, we wanted to see whether still the strategy would work. But we could repeat this on many occasions. And we also set a national record with the Limca book for the providing this comprehensive services for almost 8,469 children in one day. So a strong evidence-based answer to the questions that we had from the community, from all our stakeholders, whether without compromising on the quality, we will be able to cater to more children. This evidence gave us answers to our stakeholders' question. Yes, it is doable and it could be adopted by optometry schools who wants to take up this initiative. So we moved on to our other questions. Okay, yes, we are doing a lot of screening. We are catering to so many children. All of us do a lot of school-age screening programs, is it not? But we had a question in our mind. We give spectacles free of cost to our children. But are they using these spectacles that we give? That was the question that we had in our mind long back in 2010 when all this was initiated. We were seeing the protocols and everything in place. This was the pertinent question that we had in mind. And if they are using or not using the spectacles, what could be the reason for the child using or not using the spectacles? So this was a question that our entire community team had in our mind. So again, what we did, we thought we should explore this based on research. And we said, why are children, we did a pilot work and we found out that out of 100 spectacles that we were giving, only 18 children were using their spectacles. It was just 18%. That was a pilot study way back in 2010. But we wanted to start a research to understand why children are not wearing spectacles given in a school-age screening program. So often, I'm sure you would have heard a lot of answers, like why is the child not wearing spectacles? They'll say, people make fun of me, so I don't wear spectacles. My friends tease me, I don't wear spectacles. Or some will say, I have eye strain when my eyes are paining, I don't want to use my spectacles. I don't like my spectacles. All these are the common reasons that all of us know. We are all, whoever is part of the community outreach in school, involved in school-age screening, everybody knows this. But we wanted to know whether that is all. These are the only reasons that is making a child not wear a spectacle. So what we did, we schemed a study, which is a qualitative research. Why qualitative research? Because whenever you want to understand the perspectives of people or the attitudes of people, qualitative research is best suited for that. It will have a lot of textual information, unlike the other studies that you frequently encounter with a lot of numbers. You have numbers, you say this proportion has this proportion has this. Unlike that, Qualitative studies have a lot of textual information, like you want to understand the feelings of people, attitudes, behaviors, then qualitative research is best suited for that. Now we wanted to understand the reasons why children are not wearing spectacles. So we didn't want to restrict them. So we conducted focus group discussions with all the stakeholders of school eye screening, including the children, the teachers, the parents, the school authorities, those social workers and eye care professionals who are involved in the school eye screening program. When we did this, predominantly we included the adolescent children and their parents, the children who had refractive errors. But when we did this study, when we did this research, we found almost 108 reasons that a child will have for not wearing spectacles. Okay. So only a very systematic research could lead us to finding out all possible answers of a very common problem. That is what we realized when we completed this part of this. So we not only, so this is our publication, which told us about the different reasons. For easy representation, we broadly classified these challenges that a child encounters into physical barriers, psychological barriers, societal barriers. Like these major divisions were made, but there were almost 108 reasons for a child not wearing spectacles. So we not only explored the challenges, but we also explored the solutions. Okay, we wanted to know the solutions. Often, the solutions are decided by eye care professional. Oh, if he is having the problem, let us do this. But we didn't want to do that. We asked the solution from the beneficiaries, from the stakeholders, like the children and the parents. We asked them for the solutions. So this study outlined both the challenges, that is the barriers for spectacle complaints, and the solutions for spectacle complaints. So we had enough evidence, enough proof for our questions as to, yes, the complaints is low. Not all children for whom we give spectacles use them. That is the answer for our first question. And then our next question was, are there reasons for a child not using their spectacles? Yes, we found the reasons to be many, and not few reasons, but there were many reasons. So what we did, what did we do further? So we now have the barriers, we now have the solution. So what are we going to do with this? Research should not stop only with finding an answer. It should lead us to something else, as to a continuity, as to what else is required to improve this. Now the situation is not good. We know that we have to improve it. So we also took it to, not only the research should not lie with the scientific team alone. So we ensured that we published this in the local newspapers, national newspapers, and we made our share of contribution to inform people as to why a child is not wearing spectacles. There were enough reasons, like scars on the nose and behind the ears, the frames, the children didn't like the frames. They faced discrimination when they were using the spectacles. No, children said, I am alienated, I am discriminated. And the fear of the children, fear for many things. Okay, this fear of children never was brought out in many studies. And one important point is non-involvement of parents in most of the school screening programs. Then, the parents were never informed about the status of refractive error of the children, and how will they ensure that the child is going to wear it, or how will they ensure that annual examination will be done for the children to change their spectacles. So never parents were involved in the school eye screening process. So all these were brought out from the studies, apart from the societal attitudes of no discrimination, alienation, teasing, and friends teasing, everything. There were so many other reasons that were brought out from the study, and we also made sure that it was taken to the public through articles in the newspapers and all. So once we did that, okay, what is the next step? Our research didn't stop with it. Now we know the problems. We ensured that we told the problems to the stakeholders and also the general public. Now, how do we change the status? We have solutions. We have had a lot of solutions. What the children gave, the parents gave. There were a lot of ideas from the children and parents that will make them wear the spectacles. They wanted stylish frames. They wanted to choose the frames on their own. So there were a lot of such ideas that these people gave. But having said that, is it even possible to implement all the ideas? Is it possible? And during this time, there were also other studies, give an education, give a lecture, give an awareness session, and then that study said if you give an awareness whether it will improve complaints. And there were also other studies which said that if you incentivize the teacher, you motivate the teacher will inherently motivate the children and make them wear the spectacles. So there were a lot of studies that came up during this time when we wanted to improve the compliance. But what we wanted to see was whether there are so many problems, 100 odd problems are there, barriers are there to stop a child from wearing spectacle. Will one solution change all this? That was the question that we had in our mind. Will all, or we should have multiple solutions to cater to different problems? This was the question that we had. Is it logistically possible to have multiple solutions to school children's screening or not small programs? These are all big programs. Okay. So is it even possible to implement all these solutions? That was the big question that our research team and the community IFRI team had. So what did we do? Again, we surrendered in the feet of the research, and then we asked pertinent questions which will help us improve the compliance. Okay, so we started a research study to understand which interventions will improve. Okay, so from the solutions, from our previous research, whatever solutions we identified, we made it as a theme. Okay, and this theme we broadly divided into frame and fit related interventions, education and motivation related interventions, and the last one was how we conduct the screening. The professional conduct of the screening by itself became the third theme from the solution. So the answers that we got from our previous research, we took it to the team again, the team of stakeholders, the children and beneficiaries, the parents, and we asked them whether these solutions look okay to them. So that was the process that we followed before deciding on a package of interventions. So we had two teams in this research, the new research that we wanted to do. So we had a control arm, we had an intervention arm. We separated the schools based on this. So what did we do? The set of control schools did not receive any intervention, but it underwent the regular school screening program. But the set of intervention schools had these extra interventions in place, the three theme-based interventions that we had. And you can see that education, meeting of parents were all part of these three interventions. Like whatever the solutions that were given, we had a 23-step intervention package which fit into these three themes, and the intervention schools had this. So what happened to the results of this study? So when we saw at the baseline and for the control schools and the intervention schools and how it changed, we also didn't stop at one visit. We saw them after 1 month, we saw them after 4 months, we saw them after a year also. And we wanted to see whether there is a change in the complaints. So we found after implementing the 23-step intervention, we found in the intervention schools, the complaints went up to 46% after 1 month of time, whereas in the control schools, it was only 17.6%. But after 4 months, when we saw the control schools had 23% complaints and the intervention schools retained the 49% of complaints. So our study proved that a 23-step intervention package based on these three themes will definitely have an improvement in the spectacle complaints if you do not give when compared to a control group which do not receive any intervention. So this became a model for all our other school eye screening programs where we ensured that these intervention packages, this 23-step intervention, were put into place, and we ensured that there is an improvement in complaints. And I am very happy to share, though it is not, it is yet to be scientifically published, the recent school eye screening program of which ESO and Elite School of Optometry and Shankar Netralia were part of in the REACH, Refractive Error Among Children. We recently analyzed and we found that the complaints was with these interventions, it was much more than 50%, 50 to 60%. It was an annual follow-up, and still we could see that the complaints is maintained at 50 to 60%. So definitely the interventions were needed, and we had a robust methodology, this 23-step intervention package, which showed us enough evidence that these interventions are required, and just doing a school eye screening is not enough. Ensuring that spectacle compliance is improved is needed. But still 60% is not 100%. We will have to work more to see how it can be further improved. That is what our team concluded finally, the research and the community eye health team. Yes, so we did our homework of asking the right questions, what according to the needs in the community, what is needed. School eye health programs cater to millions of children, for it in the entire country throughout the years. So when we do this school eye screening program should effectively contribute to eliminating avoidable blindness. So that was the need that we kept in our mind before we decided our research questions, for which we can find an answer. But was that enough? That was our question. We improve the vision when we give spectacle to a child. We improve the vision to 6x6, is it not? And we also give free spectacles in most of the school eye screening programs. And I said that we also intervene. We give interventions to see that the compliance is improved. But though we do all this based on scientific evidence, research, everything is done. Is that enough? That was the question that our research team, our community team had in mind. So what did we do further? We asked further more questions. Are we satisfied with what we are doing now? Is this enough? Then we went and saw the schools which we were catering to. And we saw, our team wanted to see whether the demands that was raised by the classrooms and the classroom environments, it meets the visual requirements of children, or is it otherwise? I am very happy to say that Dr. Kalpa, who is moderating the session, is the lead author of this great work. And their research team came up with an answer that, is it enough if we give vision 6x6 vision with his or her spectacle to a child and ensures that he wears them through the interventions to improve compliance? What if the teacher is writing so small on the board that the child, even with the 6x3 vision, will not be able to see that? No, we had these questions. So what does this study contribute? How are the boards in the school? Sorry, that's another aspect of the study. How are the boards in the school that do not have adequate contrast? Vision is tested with 100% contrast, but is 100% contrast available in all the schools in the blackboards when they write, when the teacher writes on the blackboard? So these were some questions that we had in mind. So we wanted to find out whether the classrooms meet the visual requirements of the children, or these are available, the classrooms are according to the recommended vision standards. So our team found out that the vision standards for the classrooms, how big the size of the letter should be in the board in which the teacher writes. No, the team found out that a minimum size of the letter should be 3.2 centimeters, which will be like this much of a size. I hope you can see my hand. So covering all the 4 fingers of your palm. So that big, that should be the minimum size that the teacher writes on a blackboard, so that any child will be able to see whether the child is sitting on the front or the back. If these visual requirements, these size requirements also have to be met. So it is not enough if, as optometrists, we give 6x6 vision and we ensure that the child is wearing spectacle. We also wanted to ensure that the teacher writes big and the distance between the blackboard and the front bench should be at least 2.2 meters. That's the minimum. But whether the classrooms were following these standards, these were given as recommendations to the schools also. So it's not enough that if we look at these problems from one perspective, different perspectives were required. Even in the small program, it is one of the programs only. The school eye health programs are one component of the bigger community outreach initiatives. And even in the school eye health, if we had so many questions that we wanted to find answers for, I'm sure the other questions in the other fields of the community eye health, the other blindness causing conditions, vision impairment causing conditions, there are going to be more questions on these two. So And again, we didn't stop with publishing it scientifically. We also wrote articles so that it will reach to the general public, it will reach to the teachers. We made calendars and gave it to the school teachers with these information so that they will remember always that this is the size that they should be writing on the blackboard, so that children with all visual all status of vision will be able to look at the blackboard very, very clearly. So these are a few of the things that came out of the research team, only from the school eye health team, but there were many more questions that need to be answered. So if we see additional more questions and more answers, there were enough more questions with our team. So why we were thinking about, when we were working to see whether the single day mass vision screening strategy can cater to more number of children, our team realized that the visual acuity charts that we were using, that serves the purpose of screening, that is catering to this single day mass vision screening needs. So that's when our team, the research team, along with the community team, the research division of Elite School of Optometry, brought out this pocket vision screener. It's called as Elite School of Optometry's pocket vision screener. The idea behind this is it only has the 6:9 optotypes. Of course, it takes care of the crowding phenomena that is needed to find out amblyopes. So this pocket vision screener actually helps us to differentiate between the normals between the children who have normal vision, at least a 6:9, and those who do not have 6:9 vision. So this becomes a very, this system of separating people with 6:9 and not 6:9 made the process very, very fast. And that's why we were able to complete the single day mass vision screening, catering to huge number of children. So the idea of this pocket vision screener came from our research team, and it was implemented well across the different school eye screening programs of not only our institution, it is being used currently by many different institutions. So the needs decides the question for research in community eye health. And furthermore, when we upgraded our protocol, then we realized that we wanted to include screening for color vision deficiency in our comprehensive school screening protocol. Then we realized that we were only using the Ishihara pseudo-isochromatic plates. It's the gold standard for identifying color vision deficiency, congenital color vision deficiency. But Ishihara, the original Ishihara, is a very costly chart. And again, when we see it's manufactured using plant dyes, and it was not available for use for many years because multiple people handle it in the community, and it frequently gets soiled, and you cannot touch anywhere in the center, and there is no control over all that, and it takes a longer time than what we would like to have when we want to do the single day strategy or we want to cover more children. So keeping all these disadvantages in mind, we wanted to develop a quick color vision screener. So again, our institution's research team wanted to find out whether there is an alternative that could be made for screening color vision deficiency quickly. So one of our alumni and ESO joined together, and we constructed and validated a quick color vision screener. And this color vision screener served the purpose. And then the screening could be done. This is a material made of a plastic polymer, so you can even wipe out if it gets soiled. You can just wipe it with the damp cloth, and then we can use it as many times as possible. The durability of the screener is more, and then it just takes 1/5 of the time that we use with the Ishihara pseudo-isochromatic plates. This only uses 1/5 of the time, and the cost is also much lesser when we compare to the Ishihara. So the questions that we had as part of the process was converted into research, and we could come up with publications about all these things. Based on scientific evidence, we found out answers for our problems, and then we marched ahead with the solution. And that is how our community eye health research developed in the last few years, to the extent that we are doing right now. And yes, questions keep growing. It doesn't stop. And with these color vision screening, I'll just take last few slides, Kalpa, I'm almost done. So this is the work that we wanted to do after we developed the color vision screening. When we started doing the REACH project, then we found out that color vision screening should be made part of the protocol. And we found out that the prevalence of color vision deficiency is almost 2.76% among the school-going boys in South India. So this was from a big study of covering almost 3 lakh children in from the Kanchipuram district in South India. So again, we could find the prevalence. And this is another interesting point to note, that we found that though the prevalence kept on increasing among the children, myopia kept on increasing, everybody started projecting the increased prevalence. We found that when we did school screening among tribal school children in South India, we found the prevalence of refractive error to be much, much lesser, like very much lesser than anywhere reported in the literature, only 0.30%. So these were some of the other research findings from the community eye health team. So something which is different that should get attention, and we should try to learn from this model and see whether the refractive error could be reduced in any other high prevalence clusters that we see. Are there questions that remain unanswered? Yes, there are many questions that need answers. This is a recent publication from the country of China. And we can see that post home confinement, there is an increased progression of myopia. We definitely, I am sure there are a lot of teams working on the status of myopia in India also. And there are predictions about the increase in the myopia. With these increase in the progression of myopia, are there going to be changes in the prediction trends? These are questions that need answers. And everybody is talking now about increasing myopia, increasing changes, trends, and progression. What do myopes think about all these things? How do they feel about their eyes, their vision? Are they worried? They are scared? These are questions that remain unanswered now. Yes, more questions from the community eye health team. More questions. If you are eager to find answers, yes, join the research team and welcome to this eye health research. Be a part of the community eye health team, and we are all happy to join hands. And thank you again, IVA, for the wonderful opportunity. Thanks, Kalpa.
Thank you, Dr. Anuradha, for your insights on research in community eye health and sharing, the key findings from the wonderful research that you all are doing. We have a few questions from audience, but due to want of time, I'll just keep it short. Maybe I will take 1 or 2 questions. So is on if the spherical is low and if your cylindrical value is higher, and say, for example, if your spherical equivalent becomes greater than 5 diopters, then would you categorize it under high myopia or?
Ideally speaking, I appreciate this question very much, because this is what we also encountered. No, if it is a plane over the -5 cylinder, he is going to be termed as a -2.5 diopter myope. Okay, so this is how the reporting has been. But as I told you, the ideal way of doing this, or what the evidence has quoted, is using a vector analysis to represent the refractive error. But it's little complicated, so people have kept to spherical equivalent methods, and that's how most of the times prevalence has been represented. So that's why we wanted to show that astigmatism can also be separately reported. Apart from reporting on the spherical equivalent methods of myopia and hyperopia, there is also a scope of reporting astigmatism separately. So it's a very valid question, and reporting should take into consideration these aspects, and maybe give astigmatism a separate paragraph when you report the prevalence. That's what I would suggest.
Thank you, Dr. Ananda. And one last question. Is there any specific question that was used for the spectacle compliance study? This is from audience.
Questionnaire?
Was there any specific questionnaire that was used for the spectacle compliance study?
There are no validated questionnaires for understanding the spectacle compliance as of now. But yes, we did develop a semi-structured survey question, and it covered aspects. But if needed, please mail me. I can put my email ID and I can share that with you.
Thank you. Thank you. I'm afraid we don't have much time to take more questions.
Maybe I can take one or two if you have time. 5 minutes. I think it's 4:50. If you have,
okay.
You can tell me. Otherwise, we can just wind up. No problem.
Okay. Dr. Ananda, what is the minimal battery of tests that you feel is important for any vision screening, the child vision screening?
So this minimal battery will depend on the needs again. So I would say definitely the status of vision is the first requirement, definitely. And understanding about the status of refractive error is these are the minimum requirements. But when there is an increase in prevalence of some conditions, definitely we need to think about the other batteries that we have to include. Why we included color vision deficiency? Because most of the places color vision deficiency is not included in the minimum battery of screening. But we found that when we are not screening them for that, they enroll into careers that are making color, that needs color vision as a mandate, but people do not realize they complete their studies, courses, and then they enroll into such programs or careers, and later they have to change their profession. Okay, so that's why we wanted, it's a one-time test. You just screen somebody for color vision deficiency and you tell them that you can opt for a different course. You can counsel the parents and their teachers to inform the child as to how a decision could be made. So this minimum battery is a very contextual one, depending on the prevalence of conditions, depending on the needs of that community. Because in India, still, color vision is a requirement in many places. Color vision deficiency, people with color vision deficiency, there are restrictions in professions, unlike the other developed countries where it is not a must sometimes. So this is very contextual, this minimum battery. We included non-strabismic binocular vision anomalies based on the battery of tests, based on the prevalence of the NSBVA that is in the community. We found that almost 30% of the children have some form of NSBVA. So we included that as the minimum battery. And now I am just thinking, while you are asking this, now with home confinement and with more and more gadgets use, I am thinking about what sort of dry eye related complaints these children are going to be facing. So maybe some battery of tests should be included in the school screening protocol, but invasive procedures or contact procedures, how it can be done, operational logistics are there, feasibility is there. But battery is decided based on the needs of the community, based on the prevalence of the conditions that are going to be there. So the right question will decide the battery of tests.
Thank you. Thank you, Dr. Ananda. And thank you again for sharing the research activities in eye health. And congratulations and best wishes to you and your research team for the excellent work that you guys are doing. Thank you again from India Vision Institute. And thank you, audience, for joining us today for the IVI's Excellence and Vision Science lecture series and making this session interactive. Thank you, Dr. Anuradha, again for joining us.
Thank you, Kalpa. It was a pleasure. And thanks a lot for giving an opportunity to share our experience and learning that we got. Thank you. Thank you.
Thank you. Thank you. So our next session of the Excellence in Vision Science lecture series will be in March. So stay tuned to IVI's social media platforms for the details of the upcoming programs and sessions. Have a nice evening. Bye, everyone.
Bye-bye. Thank you, Kalpa. Thanks a lot.
Thank you.